Today's call is being recorded. If you have any objections, you may disconnect at this time. Participants are in a listen-only mode until the question and answer portion of today's conference. At that time, you may press star 1 on your phone to ask a question. I would now like to turn the conference over to your host, Laura Morrell. Thank you. You may begin.
Thank you, Sarah. Good afternoon, everyone. My name is Laura Morrell, and I work in the One Health Office of the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of the One Health Office, I'm pleased to welcome you to the monthly Zoonoses and One Health Updates call on December 4th, 2019. ZOHU call content is directed to epidemiologists, laboratorians, scientists, physicians, nurses, veterinarians, animal health officials, and other public health professionals at the federal, state, and local levels. Please be aware that CDC has no control over who participates on this conference call. Therefore, please exercise discretion on sensitive content and material, as confidentiality during these calls cannot be guaranteed. Today's call is being recorded, so if you have any objections, you may disconnect. Detailed instructions for obtaining free continuing education are available on our website and will be given at the end of this call. These presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. The Planning Committee reviewed content to ensure there is no bias. CDC did not accept commercial support for this activity. CDC, our planners, presenters, and their spouses or partners disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Before we begin today's presentation, Dr. Casey Barton-Baravesh, Director of CDC's One Health Office, will share some news and updates with you.
Hi, everyone. Thank you for joining us for today's ZOHU call, and welcome to all of our new call participants. The ZOHU call audience continues to grow, and we have subscribers representing professionals from government, non-governmental organizations, industry, and academia, including students. We really appreciate your help spreading the word about the ZOHU call, so please continue to share the ZOHU call website link with your colleagues from human, animal, environment, and other relevant sectors. The site includes links to past call recordings, information on free continuing education for a variety of professionals, and also a link to subscribe to the ZOHU call email list. To begin today's call, I'd like to share some highlights from the One Health news from CDC included in today's ZOHU call email newsletter. First, CDC's 2019 Antibiotic Resistance Threats Report is available online. We'll have a presentation about this report on today's call. The Council to Improve Foodborne Outbreak Response invites public comment on the 3rd edition of its Guidelines for Foodborne Disease Outbreak Response, and CDC's new typhus fact sheet is available in 6 languages. There's some upcoming webinars of interest that include CDC's updated guidance for the use of intravenous artesunate to treat severe malaria in the United States on December 10th, and the National Association of County and City Health Officials will present Leveraging One Health Collaborations to Enhance Investigation Capacity on December 12th. We've shared links to recent publications on several topics, including genomic epidemiology as a public health tool to combat mosquito-borne virus outbreaks, a multi-state outbreak of salmonella infections linked to raw turkey products in the U.S., botulism type E after consumption of salt-cured fish in New Jersey, and the December EID journal has a zoonoses theme. Regarding outbreaks, new outbreaks have been posted for E. coli infections linked to romaine lettuce and hepatitis A virus infections linked to fresh blackberries. Updates have been posted for outbreaks of listeria and an outbreak of salmonella infections linked to ground beef. There's a selected list of ongoing and past U.S. outbreaks of zoonotic diseases, as well as information on staying safe and healthy around animals, available on CDC's Healthy Pets, Healthy People website. And as always, the complete current CDC outbreak list, including foodborne outbreaks, is available at cdc.gov/outbreaks. If you would like for us to share news from your organization, or if you want to suggest presentation topics, or even volunteer to present yourself, please contact us at zohucall@cdc.gov. Again, thank you so much for supporting the ZOHU call and for joining us today. We've got an exciting lineup of speakers and topics. I'll now turn the call back over to Laura.
Thank you. Today's presentations will address one or more of the following objectives. Describe 2 key points from each presentation. Describe how a multi-sectoral One Health approach can be applied to the presentation topics. Identify an implication for animal and human health. Identify a One Health approach strategy for prevention, detection, or response to public health threats. And identify 2 new resources from CDC partners. Questions for all presenters will be taken at the end of the call. Call 1-800-857-9665 and enter participant passcode 6236326. Press star 1 and give the operator your name and affiliation. Please name the presenter or topic at the beginning of each question. You'll find resources and links for all presentations on our website and in today's ZOHU call email. Our first presentation, One Health and Veterinary Education, Advancing Career Opportunities that Address Societal Needs, will be given by Dr. Michael Larimore. Please begin when you're ready.
Thank you, and I'd like to thank all of those at the National Center for Emerging and Zoonotic Diseases and One Health Office for this opportunity to present One Health and Educational Opportunities. I would like to begin by emphasizing the concept of One Health as an approach which intersects animals, people, and the environment. And this approach requires, This approach requires the interaction across disciplines, ranging from veterinary medicine, public health, to engineering and ecology, and a cooperative spirit and knowledge and skills to appreciate how multiple disciplines view a societal issue. Viewed from the perspective of the AVMA and the AVMC Council of Education, which accredits veterinary colleges and schools in the U.S., we can see elements of the One Health within the curriculum standards, and these include an emphasis on central biological principles, understanding natural history of disease, and principles of the relationship of animals and the environment, including public health. Studies such as the National Research Council's report on the workforce needs in veterinary medicine were published in 2013, have identified the value of the One Health approach to address complex global problems, including food security. We also know from the NIH Physician Scientist Workforce Working Group report of 2014 that veterinary sciences are considered a unique workforce in biomedical research and in understanding emerging epidemics, but are a relatively small workforce in the overall field. The Association of American Veterinary Medical Colleges works to engage member institutions and faculty in the One Health initiatives underway in federal and international agencies, including the NIH, World Health Organization, CDC, and others. This includes sponsorship of the Consortium of Universities of Global Health, which has developed an interest group on global environmental health and One Health, and will be part of the 2020 meeting focused on global health in a time of worldwide political change. Viewed from the global perspective, we find the need for One Health approach at the interface of animals, livestock, and wildlife health. This intersection often involves increased contact between humans, livestock, and wildlife, as well as cycles of factors that influence outcomes related to disease transmission, such as economic pressures and land use. The United Nations Sustainable Goals include many One Health indicators of the ability of food systems to withstand shocks, whether natural or man-made, as part of the sustainable global food security and the need for government policies to preserve the environment and natural resources and sustain ecosystems. At UC Davis, we found that bringing real-world examples of the One Health approach into the classroom is a compelling way to educate students. These include examples from international projects such as the Health for Animals and Livelihood Improvement, the HALI project, a collaborative One Health-based program in Tanzania, and the Gorilla Docs program based in Rwanda. Inspired by these case studies and using pilot courses, we have created a new undergraduate major called Global Disease Biology in collaboration with our colleagues at the UC Davis College of Agriculture and Environmental Sciences. This major, which is one of the fastest growing on campus, allows students to study disease and its relationship to the health of people, animals, and plants, as well as the environment in a global context, and uses an interdisciplinary approach to advance the understanding of diseases, societal impact, as well as the evolution and prevention of disease. We've also supported important extracurricular experiences for our students, including participation in the Veterinary Student Day at the Centers for Disease Control and Prevention. We've also found that One Health approach excites our students to work in underserved communities. And these communities include Knights Landing, California, which is an economically underserved community with a large migrant population. The goal of the project is to improve health at the community level. This can be extended to One Health experiences globally, which is fostered by our Office of Global Programs and supports students to work across discipline boundaries at the interconnectedness of humans and animals, but in this context, globally, to provide community-based services. One of the projects is RX for One Health, which provides a, quote, prescription for advanced students and early career professionals to prepare them for immediate engagement in global health careers that will demand effective problem-solving skills in a cross-disciplinary manner and solid foundations in field and laboratory work. In Tanzania and Nepal, recent poultry projects showed the important role of veterinarians and extension agents in their communities. They found that school children collecting data on household poultry production produced a more accurate result than research staff visiting the households. At UC Davis, the One Health Institute has been integral in global surveillance of zoonotic diseases and capacity building through its leadership of the PREDICT program, a project aimed to define and find viruses before they spill over into humans. Last year, the PREDICT project announced the discoveries of new viruses, new Ebola viruses, closely related cousin Marburg virus in bats in Sierra Leone. Dr. Brian Bird is a recent example of a veterinary scientist trained in One Health that helped lead the CDC Ebola field laboratory in Sierra Leone in 2015. He's now a faculty member at UC Davis, continuing his One Health work. The work from the PREDICT grant formed the basis of a new consortium to enhance global health security through university networks and member institutions in Africa and Southeast Asia by developing training programs and using the One Health approach. The education of the One Health workforce through interdisciplinary research provides clear examples of how this approach serves to address complex health issues at this interface. Dr. Chris Barker and colleagues have developed a CDC-funded Center of Excellence that involves multiple universities and agencies. The Pacific Southwest Regional Center of Excellence in Vector-Borne Diseases includes these partners with approaches in surveillance, vector control, genetics, and epidemiological tools, but importantly, also to train public health professionals in other sciences. One Health approaches are used by the Western Institute of Food Safety and Security and cooperative extension research to investigate and identify solutions to complex challenges in agriculture, from food safety and disease surveillance to biotechnology and animal welfare. These field-based examples are then utilized to create food safety educational materials for stakeholders and government agencies, such as the FDA. These programs have assisted in the implementation of the Food Modernization Act in context to large food-producing systems. These agriculture-based One Health courses support the goals of Homeland Security national preparedness systems as well, and are tailored for people specifically in rural regions of the United States. Across the country, linked through the National Animal Health Laboratory Systems, are laboratory systems that utilize the One Health principles to protect the health of our nation's food supply. A recent example was the effort in California with the USDA to detect and form an eradication program against exotic Newcastle disease. Antimicrobial resistance, as you'll hear about, is a major threat to the health of the world's population and future economies of many countries. A collaborative project co-sponsored by the AAVMC and the Association of Public and Land-Grant Universities, APLU, helped form a National Institute of Antimicrobial Resistance at Iowa State University. The Institute uses a One Health approach to address the problem and will serve as a national resource for coordinating and focusing the efforts of various stakeholders, organizations, and institutions from academia, government, and industry. We must not forget that the One Health educational approaches are equally critical in small-scale farming and emerging trends in urban agriculture. These markets have been recognized by the USDA, which is funding One Health approaches to determine disease risk and educational needs for the stakeholders involved. The parallels in naturally occurring diseases between humans and animals provides multiple examples of how One Health approaches are being used to apply to education and research approaches at the interface of human and animal health. The Clinical and Translational Science Award One Health Alliance is a consortium of 15 veterinary schools partnered through the NIH Clinical Translational Science Award Network. It leverages the expertise of physicians, research scientists, veterinarians, and other professionals to accelerate translational research. Recent examples in non-human primate models of inherited retinal disease provide great examples of therapeutic testing grounds for gene replacement. A recent discovery in a genetic mutation across dog breeds that's responsible for chondrodystrophy provided fundamental knowledge of the importance of a retrogene in dwarfism in humans. Another example was the efficacy of mesenchymal stem cells to treat chronic gingivostomatitis in cats, which is similar to human oral lipoplanus. We also see examples in hypertrophic cardiomyopathy, parallels between the feline and the humans in a study designed to look at new therapeutics. Comparative oncology using the One Health principles have led to new discoveries in cancer treatments and also recent examples of proof of mechanism of new inhibitors that highlight the value of the NCI comparative oncology program. These result in clinical trials at multiple institutions, and these One Health approaches to advance the standard of care of veterinary and human medicine through these organized trials has received great attention across the country. These clinical trials have proved a dual benefit of advancing human health, but animal health, but also adding data that shorten time for the approval of human drugs. One Health approaches often applied to wildlife conservation and ecosystem health perspectives. A clear example was the elucidation of toxoplasmosis, a major cause of sea otter mortality off the coast of California. Greater attention in the patterns of emergence of wildlife cancer has offered interesting and novel insights into potential unique non-age-related mechanism of carcinogenesis across the country. As we look to the future, One Health approaches will need to be considered how information technology and data science will be used to identify effective ways of machine learning, telemedicine, and telecommunication in this context. A recent example from Dr. Titus Brown's group used existing data with new tools to more accurately identify trends across data sets. One Health approaches will be needed as we interpret data science in context to animals' environmental and human health. A clear example in the Center for Animal Disease Modeling and Surveillance provides coordinated multidisciplinary ongoing research efforts to model disease and predict future disease and also the risk of disease entering the U.S. and evaluating alternative strategies for mitigation. Undoubtedly, finally, One Health trained scientists will be drawn to the concept of planetary health that has emerged subsequent to the One Health movement. This newer concept has foundations in One Health and emphasizes the application of interdisciplinary research knowledge to improve human health with respect to the integrity of natural systems. I'd like to thank you for listening and for your support, all of you listening on the support of One Health. Thank you.
Thank you. Our next presentation, Zoonotic Mycobacterium bovis disease in deer hunters in Michigan, 2002 to 2017, is by Dr. James Sundstrom. Please begin when you're ready.
Hello, and thank you for inviting us to present this interesting topic. This was published in MMWR on September 20th and involves a multidisciplinary group. I represent Michigan Department of Health and Human Services. We've got involvement from the School of Public Health at University of Michigan, from the Michigan Department of Natural Resources, from USDA, and from a local hospital system in northern Michigan, which diagnosed a recent case of Mycobacterium bovis in a deer hunter. This article it was a brief report in MMWR and generated quite a bit of attention, and the MMWR site lists the metrics with 22,000 views. It also made the front page of the Detroit Free Press related to hunting-related tuberculosis. And the figure in this report, and I'll spend a little bit of time going over it. It starts on the right-hand side with a figure of a human being with pulmonary TB in red. This was the case that was diagnosed 2 years ago in northeastern Michigan along the shores of Lake Huron. And this was an older gentleman, 77 years old, who had been a deer hunter for many, many years. He was a little bit immune suppressed, and he was found to have pulmonary tuberculosis, and it surprised the local doctors when it turned out was identified as Mycobacterium bovis. This was quickly appreciated at the state health department because this patient resided in an endemic area with Zoonotic Mycobacterium being present in wild deer and cattle, and as a result his isolate underwent whole genome sequencing, and the purpose of this tree is to show that his isolate was very closely related to an isolate in M. bovis. This is the dark gray circle from 2007. That was a culture obtained from a deer that was analyzed in that same area, and the patient's isolate had only one SNP difference from the deer that was recovered many years earlier. Tuberculosis has a very low mutation rate, and this suggests the patient was exposed to Mycobacterium bovis that was circulating close to that time period. These whole genome sequences in veterinary isolates are all stored at USDA, and they have a library of 900 or 1,000 isolates, and they also show that it was closely linked to the blue circle, which was isolated from a cow in that same region. So we were very interested in this single human isolate that was closely linked to circulating M. bovis in northern Michigan, and I'll show you a map in a second. What we did then was go back to 2 archived cultures of Mycobacterium bovis that had been published several years ago. They were identified in deer hunters. And the middle case was another pulmonary case which dates back to 2002. When we analyzed whole genome sequencing there was a 1 SNP difference between 5 deer in gray in that circle in the middle, and also three cattle in blue. And then you can see there's some light gray circles where it spills over into some other dead-end animals such as coyotes, raccoons, or opossum. So this was a 1 SNP difference, again, very tight molecular epidemiological linkage. The third case, which had also been published previously, was a case of cutaneous tuberculosis due to M. bovis on the finger of a deer hunter. In that case, the patient's whole genome sequence had a perfect match because we could identify exactly which deer he had shot, and that was a perfect molecular match. So this gives you some background on this enzootic issue that's going on. This has been going on in northern Michigan. It was diagnosed about 25 years ago, where it was recognized there has been spillover of Mycobacterium bovis from cattle into wild deer. And currently, this photograph is what you would see today at the DNR Wildlife Disease Laboratory in Lansing, Michigan. Every day, several hundred deer heads are being submitted for analysis of their lymph nodes for evidence of Mycobacterium bovis, and there is remarkable veterinary epidemiology in the deer population in northern Michigan. going back 20 years or more. I should mention that many of these deer heads are also being evaluated for chronic wasting disease, which is causing great anxiety, and that's in a different part of Michigan. So this lab is a dual-purpose laboratory. This is one of the largest negative pressure air rooms in the United States. And this is a picture of the DNR veterinarian Dan O'Brien, who was on our publication, and he's holding a very grossly diseased lung from an animal, or from a deer diseased with Mycobacterium bovis. This is unusual to find this much disease. Often it's confined to cervical lymph nodes, which is the main organ to do surveillance on. And Dan O'Brien has provided this chart going back to 1995, showing that every year there have been culture-positive deer specimens obtained. And you can see that if you look at 2018, there were 26 deer that were analyzed with positive lymph node cultures for Mycobacterium bovis. This is out of a huge number of deers analyzed, 35,000 last year. The number of deer being analyzed has risen considerably, but that's mainly because of the concerns about chronic wasting disease. This season, deer hunting season, is just ramped up. It's in full force right now, and they've identified 7, I believe, culture-positive deer so far, and these are all confirmed by acid-fast culture. This map is to show you that this is confined to a relatively small area in northern Michigan. The yellow area involves 4 counties where the bulk of Mycobacterium bovis has been identified in deer, and then the red area is the more concentrated, higher intensity area, which is called a deer management unit, where there's been more aggressive interventions. And it's been confined to that area. There are a few other colored circles elsewhere in the state where there's been scattered herds with evidence of Mycobacterium bovis unrelated to deer, and those are usually cattle herds that had M. bovis brought in from outside of the state. So all the efforts of the Department of Natural Resources and the Department of Agriculture in northern Michigan are focused in this concentrated 4-county area. It's quite rural. It's heavily forested, where there's a lot of deer, and then there's also a lot of cattle farms mingled in. There's lots of opportunity for interaction between wild deer and cattle. So this slide shows, to zoom in on the 4-county area, this is showing the location of culture-positive deer in red that were identified last year. You can see that almost all of them are within that tighter deer management unit, and that's really where a lot of efforts are being made to try and deal with this situation. Now the next slide is showing more the interaction of deer with cattle farms, and I will explain this slide because it's presenting the infected deer as squares or rectangles. So a culture-positive deer would either be a red square or a crossed-hatched square, and you can see they're scattered across this area. But the purpose of this slide is to show the yellow dots, which identified farms with previously infected cattle herds. So there's clearly close proximity of where deer have been shot, with very close proximity to cattle farms which have been affected by Mycobacterium bovis. There are 120 cattle farms in this 4-county area, and there's been very intensive efforts to work with cattle producers and with deer hunters in this area. Every year in Michigan, and this is in the state of Michigan, in 2016, this graph shows there were 3 cattle herds in that area that were found to have evidence of M. bovis infection. You can see that this has been an ongoing issue with continued evidence of spread from wild deer into herds. In this part of the state, there are highway signs with this kind of information that where all cattle have to be tagged with an electronic identification device, and they cannot be moved outside of this region unless they have documentation of a negative bovine TB test. This issue has resulted in Michigan being identified as having a modified accredited zone status for restriction of movement of cattle, and I'm not a big expert on how that's performed, but this has put significant restrictions on movement of cattle in this area. There are quite a few efforts now at enhanced wildlife biosecurity. In other words, restricting the ability of deer to get onto farms, either by building better fences, by making sure gates are properly closed, and trying to reduce the interactions of wild deer with cattle in the area. Now, just as our case was being accepted for publication, we received notice from the health department in northern Michigan that they had identified a taxidermist with a chronic finger infection. This started about last November or December and had no response to broad-spectrum antibiotics. It was a chronic festering finger infection. They did a biopsy of this taxidermist finger and found granulomas, and Mycobacterium bovis was identified in culture. The isolate is known to be resistant to pyrazinamide, which can be used as an indirect marker for this organism. The patient did have a positive IGRA blood test. We are presently sending this patient's isolate to the USDA in Ames, Iowa, for comparison of his isolate's whole genome sequencing with the veterinary library, and those results are still pending, but we suspect that he was inoculated when he was cleaning deer heads with wire brushes. It does not appear that he can recall a specific specimen that looked different or looked diseased, so we may not have the source for that. These cases have generated a lot of discussion about what could be done next, because there's always concern about ongoing transmission to humans. So far, we've only seen diseased Mycobacterium bovis disease in deer hunters or people who handle deer carcasses. So we think that education of hunters is going to be necessary. The DNR does put some education in their hunting brochure every year about Mycobacterium bovis and chronic wasting disease. But I think emphasizing the use of gloves for field dressing of animals would be a very easy thing to do. It is very, very unknown whether airborne protection would be feasible for the tens of thousands or hundreds of thousands of deer hunters who go up to Michigan every fall. But so we just say that recommendation remains controversial. But 2 of our cases were pulmonary cases. We can speculate that those hunters got infected from a brief, intense exposure to aerosols when they were field dressing the carcass out in the woods. We would like to proceed with IGRA blood testing for hunters who submit diseased deer heads, and that's a project that we're actively working on getting going. We would also like to simultaneously be doing IGRA screening of cattle producers who have affected herds. We feel that this area represents a unique location to study zoonotic transmission of bovine TB between wild animals and domesticated animals and human beings. This topic is now gaining recognition around the world that global zoonotic tuberculosis is really being recognized. This was launched at a 2017 tuberculosis conference saying that control of human TB around the world cannot be accomplished without control of zoonotic tuberculosis. This topic has been very foreign for the TB community at large, but just earlier, a month ago in Hyderabad, India, there were 4 major sessions on zoonotic TB working to advance understanding of this topic. Thank you.
Thank you. Our final presentation, CDC's 2019 Antibiotic Resistance Threats Report, is by Michael Craig. Please begin when you're ready.
Hello all, and thanks for listening in. We're excited to give you an overview of CDC's AR Threats Report. You probably saw some of the releases in the middle of November in the news, and just want to walk through some of the pieces, and happy to give an overview. And it's in particular something that's very important to us because it is such an important One Health issue, and I think the report actually puts some finer points on that in ways that we haven't been able to before. And so thanks for the opportunity to share it with you. So I want to just highlight that some of the data pieces in the report. Importantly, CDC put out the 2013 AR Threats Report, and we used the best data available that we had at the time, but that was really pre-investment from the Congress in this topic. And so CDC put out our estimate, but we also caveated it pretty significantly when we put it out, and we've talked about it with caveats ever since then, and ever since we've sort of released our new report. And the big caveat was that we really had conservative estimates because we didn't have better data to be able to assess the burden for all the different pathogens in the report. And looking at the slides here and just advancing so you can see this, we used new data this time, and the new data that we used from primarily electronic health record data from 3 different electronic health record vendors. We pulled that together and really had data from millions of different patients across the spectrum of healthcare, and we're able to really get data specifically that not only highlighted the current burden of AR threats in the United States, but also gave us data that went back in time to when we released the first report, and it allowed us to actually recalibrate, re-estimate what the burden of AR was with these better estimates. And as you can see here with this slide, the 2 million was underestimated, and it was more like 2.6 million infections. And the deaths, notably, were underestimated pretty significantly, and they went from 23,000 to 44,000, which is an important point as a note where we are today. These are the numbers, as you can see here, about where we are with the burden of antibiotic-resistant infections and the pathogens that we highlight in the report today. Notably, we're at over 2.8 million infections. An important piece, though, is that the deaths number has actually declined from 44,000 to just a little below 36,000. And that decline is largely due to success that we've had in preventing resistant infections in hospitals in particular. The data that we had really focused on hospital settings versus community settings, and provided information specifically about the differences there. And so would highlight here that the success that we've seen and the declines overall in deaths and mortality over this period of time from roughly 2012 to 2017 is attributed to a lot of the interventions and things that we have put in place in the United States over the last decade to improve patient safety and healthcare quality in hospitals. All that being said, it's important to note, though, that if you add up the burden of the resistant threats along with the burden of C. diff, which is the companion pathogen that we include in the report because it's driven by antibiotic use, you get over 3 million infections and nearly 50,000 deaths, which is a lot of sick people and a lot of deaths that we have to deal with in the United States, and frankly, it's too many. And it's something that we need to do even more about in the United States to address. The report also does categorize pathogens, and compared to the last report would highlight for you that we have the 3 categories of urgent, serious, and concerning. And last time in the highest category of threat we had 3 pathogens, and this time we have 5 pathogens. And as you can see here, with the categories, there were 2 major changes to that urgent category list. And that is that we added a pathogen, Candida auris, which folks I think have probably heard about. This is the multi-drug-resistant fungus that we really didn't know about the last time we put out the threats report, but has since emerged and really circumnavigated the globe, and is really wreaking havoc in healthcare facilities, especially where it becomes colonized and where it becomes prevalent. And so this is one where, given its resistance, given the challenges that we face both in the United States with this pathogen as well as overseas, and given how readily it's been transmitted and really moved across the globe, we put it and added it to this highest category. We also added Acinetobacter to the urgent list, and this is somewhat of a slight definition change. In the last report we had multi-drug-resistant Acinetobacter. This time we changed it to carbapenem-resistant Acinetobacter because of specific concerns we've been seeing to specific concerns to the resistance we're seeing to carbapenems. And when we looked at that and when we redefined it and evaluated it and compared it to those other urgent threats, we saw that it was warranted to be in that higher category. I would note for you that even though we added Candida auris, the 2013 report and the 2019 report have the same number of pathogens, 18. As we categorized, we actually removed VRSA and combined it with MRSA, given the low prevalence of that and given the relationship between the two. One thing would note with the threats report, and I think it's particularly important to this group, is that we spent a lot of time and a lot of hard work with folks across the agency trying to come up with new infographics that talk about the different aspects of antibiotic resistance, and in particular talk about the challenges, the One Health challenges of antibiotic resistance, and do so in a way that is more accessible to a variety of audiences. This infographic is emblematic of that, and you can see this in greater detail in some of our online material or in the print version, and you really can't zoom in on different aspects of this to try and understand some of the relationships. So we really had twin goals of conveying high-level scientific information, but packaging it in a way where multiple audiences could understand the One Health nature of antibiotic resistance and how it touches on really any and every aspect of human life. And this is one in particular that we're proud of because we can zoom in on some of these different parts and highlight the aspects that relate to human health care, that relate to agriculture and the farm, the use of antibiotics as pesticides, but can also relate to what we deal with in our homes and in our communities day in and day out. So there's a lot of new infographics. There's a lot of new resources, both for healthcare providers. Would note that we worked with the One Health Office as well as our partners at AVMA to have a sheet on what veterinarians can do to address antibiotic resistance. For a long time, we've had companion materials on the human health side about what doctors and healthcare providers can do. But the report this time launched some other new elements like our fact sheet on what veterinarians can do. And we're proud to sort of bring that approach and improve upon how we message and how we talk about antibiotic resistance as a One Health threat. Would highlight here, these are some of the more specific data that I noted at the beginning about the success that we've seen in preventing resistant infections as well as driving down the number of deaths. And this has been the success that's really related to the hospital prevention and the hospital successes. And so you can see some of the most prominent resistant infections in the report. We have seen decreases over this period of time from 2012 to 2017. And for things like CRE, we have them on this as a success because we do consider having a stable level of CRE, given it is an urgent threat and given that we have seen it spread in other countries significantly, maintaining that at the level that we're at when we sort of expected that it would grow, we consider that a public health success. And I think it shows emblematic of the success that we've had in implementing things like the containment approach and our support to state and local health departments in identifying these emerging forms of resistance and responding to them in real time. I want to highlight, though, that this is not just a mission accomplished. There's a lot more to do. And the challenges that we see and the challenges that we highlight in the report, of course, are that the numbers are much bigger than we previously estimated. The other issues are, of course, though, that outside of hospitals, we're not seeing the same level of success. And when we defined community here, we defined healthcare facilities, that non-hospital healthcare facilities in that community bucket, as well as true community. So in both of those areas, in the non-hospital healthcare settings like nursing homes, ambulatory surgery centers, dialysis settings, we're not seeing the same level of prevention of infections and deaths, and we need to really make sure that the gains that we've had in hospitals are maintained and that we carry those successes over to other healthcare settings. Moreover, we're seeing some increases in the true community for infections that are driven in community settings like drug-resistant gonorrhea. Would highlight for you here the ESBL-producing Enterobacteriaceae in particular. That is one that these are largely drug-resistant urinary tract infections that disproportionately affect women. This is an area that needs more exploration to see all of the reasons, and we do think that there are multifactorial reasons that are driving these increases up here. But these are serious. These are urinary tract infections that previously would have been treated with an outpatient antibiotic prescription, but because of the resistance issues, folks are unfortunately having to be hospitalized to be treated. And in some cases, if those urinary tract infections proceed to the bloodstream, they can be deadly. Would also highlight for you, and we do more work in this to highlight the fact that antibiotic resistance is a global phenomenon and a global challenge. While this is a report that is focused on the United States and the threats that we face in the United States, we do note that this is one of the only pieces of data that we have around the globe about the burden of antibiotic resistance in a country. So we have good data from the U.S., we have good data from European countries. Outside of those two spheres, we don't have the same level of data and we don't have the same level of understanding of the burden of resistance. We don't have a good understanding of the emerging forms of resistance. Sometimes we are identifying emerging forms of resistance for the first time when we see them in the U.S., even though they may not have originated here. And that's a big challenge for us and a big area where we feel like there's a lot more that the global community can do and a lot more that CDC can play a role in supporting other countries of the world to address those infections. The threats report also had a new addition, which was the watch list. The watch list was a little different than the other categories of threats that we had for the other pathogens, in that these three pathogens are ones that we don't have good data on. We don't have data on burden or deaths related to these threats, but they're things that, and in fact, for some of them, they may have extremely low incidence or negligible incidence in the United States. But there are things that we're seeing either in other parts of the world or things that we are poorly understood in the U.S. and we need to have a better understanding of and move that forward for these pathogens. Would highlight in particular azole-resistant Aspergillus fumigatus there, the first one. This is one that we highlight in the report and note that this is a particular One Health threat and one that we should be aware of. Azoles are one of the main drugs and an important drug for treating fungal diseases. They're also used very widely around the world as a pesticide. And what we're seeing in parts of Europe and the U.S. is that the use of those azoles as a pesticide is creating forms of resistance that are then being inhaled to immune-compromised patients in the U.S. and in Europe and likely other parts of the world, and they are coming down with these azole-resistant Aspergillus fumigatus infections. And this is something that I think we're paying close attention to and want to learn more about some of the relationships here and figure out how we can minimize these risks and how we can figure out the best way to address these problems that we see in both our plants as well as in people. The report does also highlight the road ahead and highlights areas that we feel at CDC are where we need to be moving with our next action plan. Folks may be aware that we are in the final year of the CARB, Combating Antibiotic-Resistant Bacteria Action Plan. It runs from 2015 to 2020, and a new action plan is currently under development across the U.S. government. These are areas that we at CDC feel are critically important, and they're not just the public health areas, but they're things that we feel like need to be done across the spectrum of both public health as well as academics, private industry, and greater engagement really from all stakeholders from around the world. Of course, all of this we sort of see through a One Health approach, and we're taking that approach as we move forward with the new CARB 2.0 action plan, which we hope to be released early next calendar year. And with that, I will stop.
Thank you. At this time, we'd like to take questions for any of our presenters. Call 1-800-857-9665 and enter participant passcode 6236326. Press star 1 and give the operator your name and affiliation. Please name the presenter or topic at the beginning of your question. Sarah, do we have any questions?
We have no questions in queue yet. Again, to ask a question, please press star 1 and make sure your line is unmuted. Stand by for questions. We currently have no questions in the phone queue.
Okay, great. We'll move on. Instructions, I'd like to say thanks again to all of today's speakers for their excellent presentations. And then instructions for receiving free continuing education are available at cdc.gov/onehealth/ZOHU/continuing education, and the course access code is OneHealth2019. To receive free CE for today's webcast, complete the evaluation at cdc.gov/TCE online by December 9th, 2019, and a web on-demand recording of today's call will be posted online at cdc.gov/onehealth/2019/november.html by December 4th, 2019. Our next call will take place on Wednesday, February 5th at 2 p.m. Eastern Time. Please send suggestions and questions to zohucall@cdc.gov. For more information and to subscribe to our email newsletter, please visit cdc.gov/onehealth/ZOHU. Thank you for your participation. This ends today's call.
Again, thank you for your participation. You may disconnect at this time. Speakers, please stand by for post-conference.